vite. Alors, Mégane, qui est lauréate du prix de recherche Louis Bonduelle de 2010 et qui nous fait l'honneur de présenter en français son PowerPoint et qui parlera néanmoins en anglais. Donc, comment améliorer le régime alimentaire des enfants en situation de précarité? On vous écoute, merci.
Bonjour, messieurs et mesdames. I'm delighted to be back here to be able to tell you about the progress that I've made on my PhD project entitled Improving the Diets of Disadvantaged Children. So I've come here today from Southampton, which is a bit further away, a bit further south than Liverpool. It's a medium-sized city on the south coast of the UK, and you may have heard of it as the place where the Titanic set sail 100 years ago. In Southampton, I work at the Medical Research Council Life Course Epidemiology Unit, and a large body of research at the unit has focused on assessing the diets of women and looking at how their diets impact on the development of their young children, and in particular, the risk of their children developing chronic disease in later life. It's within this programme of research that my PhD fits. So as part of this work, we have developed a way of assessing quality of diet in women and children. By using validated food frequency questionnaires, we are able to calculate a score which represents the quality of diet of that individual. I'd like to start by introducing to you what I mean by quality of diet throughout this presentation. So in the children, a high diet score is characterised by the foods above the line, fruits and vegetables and whole grains, foods which represent a good quality of diet. On the other hand, a low diet score in the children is characterised by high intakes of the foods below the line, the processed foods and the fizzy drinks, foods which represent a poorer quality of diet. So I shall move on to explain to you some of the results that we've had from Southampton, which have formed the background to my PhD. First of all, we have shown that inequalities exist in the diets of young women. This graph gives you the proportion of women in the lowest quarter of quality of diet score split by their educational level. You can see that more than 50% of the women who had no formal qualifications had the poorest quality of diets, where only 3% of those with a university degree had similarly poor diets. This has implications for their young children. We also have shown that women who had a poor quality of diet went on to feed their 6-month-old infants a poorer quality diet, and that this association tracked throughout childhood. In turn, a child's quality of diet at infancy, a poor quality diet, went on to predict greater fat mass and lower IQ in the child at the age of 4 years. So clearly the diets of young women are very important, not only for their own health, but for the health of their children as well. So with this in mind, we set out to develop an intervention called the Southampton Initiative for Health. The intervention is a training intervention in which we train healthcare staff who work with women and young children in the community and particularly target those in disadvantaged areas. We trained the staff in using a conversational technique that we called healthy conversation skills, which encourages them to start using open and exploratory questions whilst having conversations with women about their health behaviours. This, using open discovery questions, really encourages the woman to identify her own challenges to changing her health behaviour, as well as identifying and coming up with her own solutions to change. So this intervention takes on an empowerment approach, not only in the staff who may start to see their practice becoming more effective, but for the woman herself who has come up with her own action plan to change, instead of just being given a leaflet or being told what to do. The evaluation of this intervention is in the form of a non-randomised controlled trial. We, at baseline, carried out a survey with women in both the intervention area of Southampton here and also control areas of Gosport and Havant. The initial survey questionnaire asked the women about their own diets and lifestyles. But given what we know about the relationship between the diets of women and their young children, we hypothesised that if we intervene to improve the diets of women, this will in turn have an impact on how they feed the diets of their young children. It is this hypothesis that forms my PhD project. So after the initial survey, we invited those women with a child aged between 2 and 5 years old to complete a second questionnaire, this time focusing on the diets and lifestyles of their young children. We followed the mothers up at the beginning of this year, but unfortunately these data are not available yet, so my presentation today will focus on the findings from the baseline survey. So the characteristics of the children in my cohort, we have 348 children altogether, roughly 50% in the intervention group and 50% in the control group, but for the purposes of this presentation I have combined them. They're just over 3 years old. We have pretty much half boys, half girls. You can see that nearly a third of our children are only children and the rest have brothers and sisters. The mothers are around the age of 33 years, and we measured the mother's educational level as a marker of disadvantage. You can see that we have nearly 40% of women who were classed as having low educational levels. We class low education as those who leave school at 16 years of age with a general certificate of secondary education qualification or lower. In the UK, it is mandatory to stay in school until you are 16 years old. Therefore, anyone we class as high education are those who chose to go on to formal education after high school. So the questionnaire that we asked the mothers about their children included a 20-item short food frequency questionnaire, and I'm going to talk more about that in the next slide. We also had a measure of food neophobia, so whether or not the child is afraid to try new foods. We have measures of the home mealtime environment. Do they sit at a table when they eat their meals? Is the television on? We also measured two very distinct styles of parental control over children's eating habits. These two styles were overt control and covert control. Overt control is the very conscious restriction or encouragement of the of the child to consume certain foods, whereas covert control is a management of the child's food environment. And again, I'm going to talk more about findings on this later on. We also measured the time that the child spent watching television. So as I mentioned, we used a short 20-item food frequency questionnaire. Given that these were mothers of young children and we were trying to do a questionnaire with them over the telephone, as well as a large proportion of the women being poorly educated and notoriously difficult to engage in research, I thought it was important to have a short dietary analysis tool. But I wanted to check that it was still giving me robust information on the child's quality of diet. So in a sub-study, I had women with young children carry out, complete a full 83-item food frequency questionnaire, and also later on the 20-item food frequency questionnaire, and I correlated the scores. And as you can see, the scores from both questionnaires were fairly highly correlated, so I can be quite confident in the information about the child's quality of diet that I was getting from this short food frequency questionnaire. And just to give you an idea, the 83-item administered food frequency questionnaire took around 45 minutes to complete, whereas my short version only took around 7. So what did the food frequency questionnaire tell me about the diets of the children in the baseline survey? We split the children up into quarters according to their diet score. And this shows the median weekly consumption of certain foods between those in the poorest quarter of diet score and those in the best quality diets. You can see the great disparity between the frequency of consumption of certain foods between the children with the poorest and best quality diets. For instance, those with the best quality diets are consuming vegetables many more times than those in the poorest quality diets. It's also worth noting that the children in the poorest quality diet quarter tended to be those with disadvantaged mothers. So moving on to some of the findings from the baseline survey, we confirmed this finding that the quality of a mother's diet is strongly associated with the quality of a child's diet. Along the x-axis, we have a level of maternal diet score in fifths, and along the y-axis, we have the child's diet score, and you can see the clear stepwise trend. We have also shown that children who had more food neophobia, who were afraid to try new foods, had poorer quality diets. Poorer quality diets were also seen in the children who watched more television or who ate their meals whilst the television was on, and also those children who did not sit at a table to eat their meals. These findings are all independent of the mother's own quality of diet, and these behaviours were also more likely in the children whose mothers were disadvantaged by lower levels of education. Whilst these results are quite interesting, they have been shown in the literature before, and I'd like to move on to one of our findings, which is a bit more novel. And this is around the style of control that a parent uses over her child's eating habits. So as I mentioned, we measured two very distinct types of control, overt and covert. So the overt control is the very conscious restriction or encouragement of the child to consume certain foods. It's more detectable by the child as well. Whereas the covert style of control is a management of the child's food environment. It's less detectable by the child. And for instance, if I was a mother using covert control and I didn't want my child to have a burger, I would not take them to McDonald's, or I would not buy burgers and have them in the house. It's about exposure to the foods. So we put overt and covert control scores of the mothers in a regression model with child's diet as the outcome. And you can see here that overt control had no apparent effect on child's quality of diet at all. So being very firm, being a mother who's very firm about what the child can eat, seemed to have no effect on the child's quality of diet. However, those mothers who used the covert control, the management of the child's food environment, had a strong positive association with the child's quality of diet. When we place this into a model with mother's quality of diet as well, the use of covert control methods remained a strong, significant independent predictor of child's quality of diet. And that can be shown quite nicely in the following graph. Along the x-axis here, we have a maternal diet quality score, this time in thirds, and of course along the y we have the child's quality of diet score. Within each third of maternal diet score, we have then divided the mothers up into thirds according to their use of covert control. What this means is the mothers in this blue line here have the poorest quality of diets and use the least amount of covert control methods, and you can see the effect it has on her child's diet. Whereas women in this column, have the best quality diets and use the most covert control methods. Now, within each quality of diet third in the mothers, you can see the clear trend that increasing covert control methods has on her child's quality of diet score. And I'm currently writing these findings up for publication. So, as I mentioned, we have carried out a follow-up survey, but the results are not available yet. But I can just introduce you to the follow-up cohort 2 years on. So we have 228 children still in our cohort, which is a 66% retention rate. As expected, the children are 2 years older, and they are now attending, or most of them will now be attending full-time education in primary school. We still have roughly half and half boys and girls, but you can see that many more of the children now have siblings. As for the mothers, well, again, they're nearly 2 years older, And we still have over a third of our women with the poorer levels of education in our cohort. This survey was carried out 2 years after baseline, which means it's not just the older and better educated mothers that we've managed to follow up, which has been the case in other longitudinal studies. So moving on to some of the questions that I shall be asking from my follow-up data, and really the principal questions for my PhD thesis. Firstly, we mustn't forget that this was all carried out as part of an evaluation of an intervention. So has the intervention had an effect on the children's quality of diet? I will look at changes in diet in the children in the intervention group and in the control group and just compare the two and see if there are any differences. Secondly, does the effect of parental control on the child's diet diminish once the child starts going to school and being fed by other people more often? And finally, what effect does the children going to school or the mothers going back to work have on aspects of the family feeding environment? My data collection is not quite yet over, as at the end of the year I shall be carrying out focus groups discussions with a subset of women with young children to further explore some of the associations that we found in the survey. The Louis Bonduelle Award has really enabled me to disseminate these results to a wide audience, both nationally and internationally, at conferences through oral and poster presentations. At the moment, we've got an article published, 2 in press and 2 in preparation. And I've also been able to set up a formal collaboration with Professor Jane Ogden from the University of Surrey. Jane is a professor of health psychology who developed the measure of overt and covert control. There's also been a bit of a wider interest in the project. I was lucky enough to be invited to a workshop for early career researchers run by the National Institute of Health Research in the UK. Whilst I was there, I presented on the work around parental control and eating habits and was awarded a prize for the presentation by Professor Dame Sally Davies, who's the Chief Medical Officer for England. So far, I'm really enjoying my PhD project, not that it isn't without its stresses at times, but it couldn't be possible without the help of many other people. So I'd like to finish today by saying a huge thank you. Firstly, to the women and children who take part in the study, my brilliant PhD supervisors, all of the people who work on the Southampton Initiative for Health, and finally, of course, to the Louis Bonduelle Foundation for their support of my research. Thanks.
Merci beaucoup, Megan Jarman, pour cette riche expérience. Et moi, j'avais une question concernant l'influence des mamans sur le régime alimentaire de leurs enfants. Est-ce qu'on a noté si les mamans mangeaient en même temps que les enfants, puisqu'on avait des jeunes enfants quand même? Est-ce que les mamans sont présentes pendant le repas, assises en même temps, ou est-ce qu'elles font manger les enfants avant? Parce qu'on sait que ça a quand même un petit impact sur la façon dont se nourrissent les enfants, le côté mimétisme finalement. Est-ce que ça, vous l'avez observé?
Yes, so one of the measures of the family feeding environment is whether or not the children eat at the same time as the rest of the family. So we do have that, in the questionnaire. So we can have a look and see if that has an effect.
Okay. Thank you.